Good morning, good evening, good afternoon, wherever you are. We are going to talk here about inguinal hernias. Surgeons love to talk about inguinal hernias. I'm not a surgeon, so I don't like to talk about inguinal hernias. Um, well, let's put it a different way. I don't like to talk about it like surgeons do. You can go in and memorize all the anatomy you want on this, and that will make you a great surgeon, but it's not going to make you any better of a clinical practitioner as far as being an internist or a pediatrician or an OBGYN or any of the other things that you might be if you're studying for step 2 or step 3. So I'm going to try to keep the anatomy down to a minimum. It's going to be hard for me to do, but I will try my best. So we're going to talk here only about the inguinal hernias, which are indirect and direct inguinal hernias. Their names don't really make a whole lot of sense to what they really are, so we'll kind of tease those apart. The other hernias I'll talk about in a different section. Those include a femoral hernia, which kind of occur in the same area as these inguinal hernias, and then incisional and umbilical hernias, and then I guess I'll probably give a few names of some other hernias and maybe some things to know about those. Alright, so some general principles of hernias. They are an abnormal protrusion of intra-abdominal contents through a relatively weakened portion of the abdominal wall. Now note that I said relatively weakened portion of the abdominal wall. I didn't say an obliterated portion. This just has to be an area of the abdominal wall that's weaker than the rest of the abdominal wall, and if your abdominal cavity can no longer contain everything that's inside it, if the intra-abdominal pressure exceeds a certain point, where's the first point things are going to start popping out? They're going to pop out at the weak point, and that weak point is where your hernia would happen. Now, this is kind of similar in nature to thinking about aneurysms. Aneurysms occur at weak areas of the vessel. And so where do we get that ballooning berry aneurysm? At the weak point of the vessel. Or if you've got diverticulosis, where do you get the tics? They occur at the weak part of the large intestine. And so that's all sort of the same physical science behind that. Now the types of hernias, inguinal area hernias are the most common, 75 to 80%, and those include the indirect and direct hernias, which we're going to talk about, along with the femoral hernias, which are in the same area. We're not going to talk about those. But this makes about 75 to 80% of all the hernias that come in. So if you know about these, you're good to go most of the time. A few others that you see a little less often are incisional hernias. That's just like its name would suggest. You cut somebody in the abdomen to do an exam, and they heal. Maybe something goes wrong with the healing process. Maybe they're immunocompromised and they don't get proper healing, and now they wind up with an incisional hernia because you didn't get proper union of the tissues. So incisional hernia is common. This is more of a post-operative complication. Umbilical hernia is something that you may see in kids, maybe see in adults sometimes too. This is 3 to 8%, and then there's some other hernias that are less common. Hernias are aggravated by anything that increases the intra-abdominal pressure. So remember what hernias are: protrusion of intra-abdominal contents through a weakened portion of the abdominal wall. In order to protrude through a portion of the abdominal wall, there had to be enough pressure there to begin with for those abdominal contents to say, oh, I don't want to be here anymore, I want to go out there where there's less pressure. So anything that increases the abdominal pressure, the intra-abdominal pressure, is going to worsen your hernia. Maybe temporarily, but it will worsen the herniation. So this can be aggravated by anything that causes straining, like constipation or coughing, lifting heavy objects, COPD, sort of vis-a-vis coughing, pregnancy, obesity, ascites. All those things increase your intra-abdominal pressure. Some terms for knowing about hernias. So most patients, when they come in to the office and they say they've got a hernia, they have a reducible hernia. And a reducible hernia is the most benign of hernias, because a reducible hernia is a hernia that can be pushed back into the abdomen. And that makes us happy, because it's like, oh, look we can push this back to where it's supposed to be. It might fall back out, but it's got room. And so a reducible hernia, while it will need to be treated, we're not as freaked out, for lack of better words. Now, an incarcerated hernia concerns us, because an incarcerated hernia is a hernia that can't be pushed back into the abdomen. You see the hernia, and you try to push it back, but you can't get that bowel back into the abdomen. This is incarcerated, and incarcerated hernias are at risk of strangulation. Strangulated hernias are a major, major, major emergency. So a strangulated hernia is where it becomes the outlet from the hernia, where it's coming out of the abdominal cavity, is constricted to no longer allow for adequate blood flow to the tissue that's in the hernia sac. And so as a result of that, you get necrosis, and that can lead to perforation of the small bowel, and that leads to all sorts of problems. You get septic, nausea, vomiting, etc. So a strangulated hernia. This is a surgical emergency. These patients will be going at 2 in the morning to get their horniorrhaphy. Whereas patients with incarcerated hernias, they may get one scheduled. Patients with reducible hernias, they might get one scheduled when the doctor feels like it. So these are kind of in order of severity. But really, what's important to remember is that a strangulated hernia is a complication of a hernia. So the fact that a patient has a reducible hernia means it's very possible they could come down the road after not getting it checked out for a year, 2, 5 years, and now they have a strangulated hernia. So you can see why, once you see the patient has a hernia, why you kind of want to operate on it and get it out of the way so that you don't have to worry about ever getting to that strangulated point. Now, an obstructing hernia is sort of different than these other three. An obstructing hernia is where, you've got the small bowel that's in your hernia loop, in your hernia sac, but what can happen is that the small bowel can kink while it's in that sac in such a way that food products cannot get through the small intestine. And if that is the case, then you have a small bowel obstruction. And so this would just be a small bowel obstruction secondary to herniation. Okay, so I do not want to go too deep into anatomy, but I probably will. So I'm just going to start out here by telling you these are your hips, as you know. And when you're looking at this, remember that your hips come out towards you, and they also, as you go inferiorly, kind of go back away from you. So this is the anterior superior iliac spine right here. Right? So here's your iliac crest, kind of moving away from you into the computer screen, and then right here is your anterior superior iliac spine. From the anterior superior iliac spine all the way to the pubic crest, you have a ligament, and that is called your inguinal ligament. And that's going to be a very, very landmark piece of anatomy as we think about the inguinal canal. Okay? Now, this was very dissected. It's even a cartoon. This is, albeit a cartoon, but it shows very little dissection. So all you've removed is skin and subcutaneous fascia. And what we see here is we see the inguinal ligament right here, going down to the pubis and up from the anterior superior iliac spine. And we also see a spermatic cord. And if I haven't said yet, the spermatic cord in the man is what goes down the inguinal canal. And the inguinal canal is what we're concerned about when we're thinking about inguinal hernias. So the inguinal canal, everything enters deep, and everything exits superficial. So the entrance, which would be your deep inguinal ring, what I have here in orange, it's just deeper, you can't see it. That is where everything enters, your broad ligament, your spermatic cord, whatever, it enters in there. And this is there for the beginning of your inguinal canal. Now, as you go towards the exit is anterior and medial. So you're kind of coming at an oblique angle here. So this is posterior and lateral. This is anterior and medial. And you wind up here at your superficial canal, or your superficial inguinal ring, and this is where everything exits. So here's your spermatic cord that's exited now, and now it's going down into the scrotum. All right. You also have these vessels here, these epigastric vessels. They're important landmark points. They're roughly at the mid point, maybe mid one-third point, if you're talking 1/3 away from the pubis, along the inguinal ligament. And that's going to be important when we talk about direct inguinal hernias. Okay, so here's your deep inguinal ring in orange. And then you got your inguinal canal, which is transmitting the spermatic cord or your broad ligament, as well as ilioinguinal nerve. And then you have your superficial inguinal ring where everything exits. So you can think of the canal, which the canal is a space, but it's not a very big space. It's just big enough to transmit whatever is being transmitted. But it is a space, and so on the space, superficially, if you were to dissect, this is a superficial view. This is everything here. This is superficial. You have aponeuroses of the external oblique, and you also have the external, or the superficial inguinal ring, right here. Okay. Now, inferiorly, so now we're thinking towards your feet, you have the inguinal ligament and the lacunar ligament, which is another much smaller ligament that you don't need to worry about. Okay, so that forms two of the walls. A wall down here on the bottom, your floor, and then a wall here, which would be your anterior wall, or superficial. Now, before I go on, I want to add that you have three muscles that are in this area that overlap each other. External abdominal oblique, internal abdominal oblique, and then transversus abdominis. And their fibers go in alternating directions. All right, and the reason I wanted to tell you that is because as you get deeper, you're going to have more fibers involved. So the deep part of the inguinal canal is made up of the deep inguinal ring, which of course is the entrance, the conjoint tendon, which is a tendon that connects two of the muscle layer sheaths and transmits it over to the pubic symphysis, I believe. And then the transversalis fascia. The transversalis fascia is fascia underneath the transversalis muscle. The transversalis muscle is the deepest most muscle when we're talking about this region. So transversalis fascia, once we get down to that region, so here's our transversalis fascia right here, we're pretty much one layer away from peritoneum. So there's not much left. So this makes up the posterior wall. And then the superior part is just going to be aponeuroses and fibers from external and internal oblique. Okay. This stuff, unless you're going to be doing operations, not so important. The stuff I tell you from here on out is much more important. So what does the inguinal canal transmit? Well, we already said it transmits the spermatic cord or the round ligament, spermatic cord in a male, round ligament in a female, and it transmits the ilioinguinal nerve for everybody. And that is true. But when we say spermatic cord, what the heck does that mean? The spermatic cord is arteries, veins, it's reproductive structures, and it also has a nerve. So you've got the testicular, deferential, and cremasteric arteries. Basically, all the arteries are going to supply the testes, all the structures around it. You have a pampiniform plexus, which is a plexus structure of veins. to drain the region. The vas deferens, which is the all-important tube for sperm to go down, or I should say up rather. And then you also carry the genital branch of the genitofemoral nerve. There's also something called the processus vaginalis. The processus vaginalis is really of no it's really of no concern to us as long as it's closed. But in about 10% of males, the processus vaginalis does not completely close, and so there's communication between the peritoneal cavity and the scrotum, and so that can cause a hydrocele. And I'm going to talk about that in a different section, but I do want to briefly bring up what a hydrocele is. That's just a connection between the abdominal cavity and your scrotal area, and so that causes a hydrocele. And a hydrocele can be misdiagnosed from a indirect inguinal hernia. And I'll show you how to differentiate the two. Okay, so what are these hernias that we're going to talk about? Indirect and direct. And their names have really not a lot to do with what they are, because it doesn't really make much sense. Indirect inguinal hernia is just a hernia of intra-abdominal contents that go through the deep inguinal ring and kind of follows the spermatic cord down through the canal, and ultimately, if it goes far enough, down into the scrotum. So look here. You have your deep inguinal ring down here, and it comes in, and then it's going to come all the way down, and it's going to keep going, keep going. You have intestine coming all the way down here. So it's just traveling down your inguinal ligament. This is an indirect inguinal hernia. A direct inguinal hernia is a herniation of intra-abdominal contents through the floor of the medial inguinal canal. So this is not through the canal. You're not going through the canal. You're going underneath it. And so you get a herniation of intra-abdominal contents underneath the medial inguinal canal, the medial part of the inguinal canal. Okay? So the indirect goes through the inguinal canal. The direct goes under it. And this area is called, where it goes under in the direct inguinal hernia, is called a Hesselbach's triangle. I don't know what I don't have it on hand what the exact anatomic boundaries are for Hesselbach's triangle, but you can look it up if you want. But what you should know about Hesselbach's triangle is that it's the medial part of the inguinal canal, and that if there's anything pushing out from underneath it, it's probably a direct inguinal hernia. Okay, so here is your deep inguinal ring, and this is where bowel contents are going to come out and herniate down the inguinal canal, and then ultimately possibly down into the testes, or into the scrotum. This is Hesselbach's triangle. Doesn't look anything like a triangle. Doesn't matter. This is where you get your direct inguinal hernia, and the only reason that it happens here and not here or here or here is because this is the weakest part surrounding the inguinal ligament. So if there's ever going to be a place where herniation is going to happen, damn well it's going to be here if it's from excess abdominal pressure, because this is the weakest portion. Can you have one in both? Yes, you can have one in both. It's called a pantaloon hernia. We're not going to talk about that. All right, so this is just a little cartoon here. So here's your indirect hernia coming in through the deep inguinal ring, going down the inguinal canal, and then ultimately, yes, can go into the scrotum. The direct inguinal hernia comes in underneath the inguinal ligament, and this does not go down into the scrotum. This just stays kind of along the inguinal canal. So this is going through the floor of the inguinal canal. I don't know if it goes underneath the inguinal ligament, but it goes through the floor of the inguinal canal. Okay, so indirect inguinal hernia. So this is herniation of intra-abdominal contents through the deep inguinal ring. The hernia follows the path of the spermatic cord. This is 5 to 10 times more common in men, has a 5% lifetime incidence, and it can occur at any point in life, and it's vital that you remember that. So if you are a male and you're watching this, 1 in 20 chance you will have an indirect inguinal hernia that will need to be operated on. So we're not above having to be patient sometimes. But this can occur at any level or at any time in life. It can be in older men. It can be in younger men. It can be, but what does unify this is that it is almost always in men. And I could not imagine them giving you a USMLE question that was an indirect inguinal hernia, and it was a female patient. That can happen, but usually they like to keep it rather classic. Now, another thing that's really important to remember from the indirect inguinal hernia is that most of the time it's due to a congenital lesion, not an acquired lesion. So an acquired lesion could be like a tear in your muscle. Like, let's say I got into some really awful accident and my muscles tore in my abdomen. That would be an acquired lesion. I could get a hernia through that tear in my abdomen. That's acquired. It's not congenital. I wasn't born with it. Patients with indirect inguinal hernias, most of the time, they get it due to congenital lesions. They didn't do anything to cause that weakness or that region of weak tissue that allowed for the hernia to enter. However, and this is why people get confused, it may be brought on by activity, because like any other hernia, it's going to be made worse or better by increased intra-abdominal pressure. So increased intra-abdominal pressure, the hernia will come out more. But the etiology of this is a congenital lesion. The symptoms are groin mass plus or minus pain. A lot of times you may see this mass even into the scrotum, but not necessarily. You should just look at the patient first. If you see any visible mass looking at them, that should be what you go for. After that, then you'll want to palpate through their scrotum. You'll also want to make sure that you're having the patient cough or strain or bearing down. And as they're bearing down, you should be able to see what this mass is much better. And of course, there are other things that can be masses that are not hernias. So what we really look for when we're thinking of hernias is a mass that is worsened with coughing or straining or bearing down or any of the other words you want to use for increasing intra-abdominal pressure. If it doesn't, then perhaps it might not be a hernia. But if it does get worse with increased intra-abdominal pressure, then that sets off towards the clinical diagnosis, and the diagnosis can be made clinically. The treatment of choice is herniorrhaphy, and that's just a fancy word for hernia repair, and that includes replacement of the abdominal contents, putting them back into the abdominal cavity, and then reinforcing the deep inguinal ring. Right, so this is just an illustration of how this happens. So here's your deep inguinal ring. And perhaps it's weakened just from a congenital defect, and now bowel has found a way to get through. And bowel can stop here, or it can stop here, or it can come all the way down here, and you can get even more coming through. And so this can get worse and worse and worse and worse, and you'll see that on some of the pictures I'm going to show you. Now, when you're looking at a patient, you should reflect their penis and look at their scrotum. If their scrotum is more full on one side than on the other, then that makes you consider that you may have a hernia going on here. So obviously this is an indirect inguinal hernia. Now would you be able to detect this from a hydrocele just from looking at it? No, not necessarily, but there is a way you can do it. This is an indirect inguinal hernia. All you have here are bowel contents coming down into the scrotum. Now, what I'm telling you that you can do to differentiate a hernia from a hydrocele is something called translumination, where you're taking a flashlight, I don't know if they have special lights for it. I just use like a pen light or something. And you're shining it through the back of their scrotum. And if it's a hydrocele, it will illuminate, because what do you have in a hydrocele? You have water. You have fluid. What do you have in a hernia? You've got tissue. You've got bowel tissue, maybe even compressed against one another. So that will not transmit light. So if you see transillumination, you're probably dealing with a hydrocele. If you don't, you're probably dealing with an indirect inguinal hernia. Here's another one. Again, this is just bowel in the, it looks like it's bilateral too. Bowel in the scrotum. Okay, now let's differentiate this from the direct inguinal hernia. This is much different. So direct inguinal hernias are herniation of intra-abdominal contents through Hesselbach's triangle, which is a weakened region of the transversalis fascia, and that's part of your floor of your inguinal canal. This is a weak point of the inguinal canal, and so remember what I said, if you have increased intra-abdominal pressure over time and things are breaking down or things are getting weaker and you still have all that coughing or straining or constipation, ultimately the bowel is going to want to go somewhere else where it can get away from that pressure. And so this is going to be one of the places where it's going to go. And this would be a direct inguinal hernia. Now, unlike an indirect inguinal hernia, where the indirect was a congenital lesion, the direct inguinal hernia is an acquired lesion. It's acquired from lifting and coughing and straining and constipation. Think of like your 55-year-old guy who's been working on the mines, does a lot of lifting, moving things from truck to truck, has a very, very, very physically taxing job. He's the one who would be at risk. He's getting older. As you get older, your tissue starts to break down a little bit, gets weaker, and so you're at higher risk for this direct inguinal hernia. So this tends to occur in older men and in older men alone. You don't see this in children so much. If anybody has seen this in a child, please let me know, and I will correct this. But you generally don't see this in children. You don't see this in young people. This is older men who do lifting. Maybe they're moving house. They're helping their freshman daughter get into her dorm room and lifting up all these big boxes. Older, middle-aged men who are doing heavy lifting. The symptoms are virtually the same. Groin mass with or without pain. Remember, the pain would be strangulated. So that's why this pain here is important. It's going to totally alter, it's not going to alter what we do, but it's going to alter how fast we do it. So plus or minus pain worsened with coughing or straining. So just like any other hernia, diagnosis is made clinically. The treatment of choice is a herniorrhaphy, just like for the indirect, and that includes reinforcement of the inguinal canal floor because that's where this came from. All right. So here is here's a direct inguinal hernia, rather, and what you see here is a hernia bulging out at you that's not going into the scrotum. And it's hard to tell that this is that this isn't an indirect inguinal hernia just by looking. Doing the physical examination will give you much more hints. But in the grand scheme of things, all you need to know is if it's an inguinal hernia or not. Because when a surgeon goes in to operate on a hernia, they're going to operate pretty much the same way if it's a direct or an indirect. The only thing that might change is their where they think they're going to be reinforcing tissue, but they'll have everything set up for them if it's direct or indirect. So it's not a big deal if a patient goes in with the pre-op diagnosis of direct inguinal hernia and winds up post-op diagnosis of an indirect inguinal hernia, and that happens. So it's not a big deal if you can't differentiate between the two. What's more important is to differentiate between the two based on the patient population. All right, here is a direct inguinal hernia in a female, and I should say that compared to indirect inguinal hernias, with direct inguinal hernias, females do have a higher likelihood to get them. Males are still way up there. Males are still way more likely to get even the direct inguinal hernia, but females can get direct inguinal hernias too. So if you're talking about a male patient, you would say that indirect, they get indirect more than they would get direct. If it's a female patient, you'd say direct more than they would get indirect. Even though for female patients, inguinal hernias altogether are rare. Hopefully that made sense. Okay, so here's the exam technique, and this is what I want to show you. This might help you get an idea of how to decide on whether it's an indirect or direct hernia, because just looking at them doesn't always help. Now, you know if you've got contents in your scrotum, it's an indirect hernia, but it doesn't always get that far. So what you're going to do is first you're going to look at the patient, and you want to use like a oblique lighting so that you may see any shadows. And you want to also have the patient tell you kind of where is this mass that you feel, and then that will at least kind of tell you what side to feel on. And what you're going to do is you're going to be essentially placing your finger in the inguinal canal. How do I do that? The inguinal canal is inside the body. Aren't I doing surgery? No, the inguinal canal is consistent with the scrotum. And so what you're going to do is you're going to move the penis over to the other side, and then take a thin area of scrotal tissue and then just gently follow the spermatic cord, and you'll be able to feel it. Guys, you can get some practice at home doing it on yourself. No shame in that. But you'll stick your finger along the inguinal cord, and you'll notice that, oh, my finger can go back here. Look at that. And you don't need to go up that far, but then what you're going to want to have the patient do is cough. And when they cough, if you feel the hernia on the tip of your finger going in, which the tip of your finger should be pointing towards the through the inguinal canal, the tip of your finger would get hit by an indirect inguinal hernia, because remember, the indirect inguinal hernia is going down the inguinal canal, and our finger is going up the inguinal canal, so they'll meet. So it'll hit your fingertip. If it is a direct inguinal hernia, you'll feel it on the sides of your fingers, and that's because rather than going down the inguinal canal, the direct inguinal hernia is beneath the inguinal canal. Okay, so you'll feel it underneath where the inguinal canal is. Hopefully that makes sense. Very difficult to teach about anatomy on slides. I have learned that. But if you have any questions, namely about how to do the physical exam, definitely ask me, because this is a really, really, really good, important part of a history and physical comprehensive for males, especially for teenage males. You're definitely going to be doing this exam if you work with pediatric patients. You've got kids coming in 15, 16 years old. They want to get signed out so that they can play sports. Hernia is one of the things that you're going to want to look for them for. Okay, so just to recap, the indirect inguinal hernia comes through the deep inguinal ring, whereas the direct inguinal hernia comes through Hesselbach's triangle, which is part of the floor of the inguinal canal. The patient population for the indirect inguinal hernia, it's males way more than females, all ages, even pediatrics. With the direct inguinal hernia, it's males greater than females, although not so much the same preponderance as with indirect inguinal hernia. And this is mostly older men. The cause for the indirect inguinal hernia is congenital weakness or patent processus vaginalis. The cause for direct inguinal hernia is aging and excessive straining. How we treat and diagnose these are all the same. So these invariably present with groin mass plus or minus pain, worsened with straining. It's diagnosed clinically. Treatment is herniorrhaphy. Asymptomatic hernias may be observed, however, it's elective repair. So there are two things, though, that I wanted to go back and tell you about regarding the indirect versus direct hernia. So look at here at the deep inguinal ring where the bowel is coming out, right? And then look here. Let's see, where have I got it? Right here, this relatively small flat area where you would have contents of your abdomen pouring out in a direct inguinal hernia. If you note, this area is much smaller than Hasselbeck's triangle. Hasselbeck's triangle is a lot bigger than this little tiny ring. And the result of that brings us to medical relevance, is that an indirect inguinal hernia is more likely to strangulate. So with patients with indirect inguinal hernias, it's extremely important that they be attended to and that you come up with some kind of solution ASAP, preferably surgical repair.